shut off the microphone to save the battery.
Good afternoon. Good afternoon, everyone. I hope you're as energized as I was by that last session on guaranteed basic income and what it means and how it helps families. This is going to be yet another session which is focusing on addressing the core and real needs of families, specifically by focusing on the social determinants of health. We have a tremendous panel, and my name is Charlie Homer. I'm a senior advisor at Empath, and I'll be moderating. And before I introduce our two wonderful panelists, and we're going to have this, after a brief presentation, we're going to have this more as a discussion amongst us and then give you an opportunity to ask questions. I want to start off with just a few remarks about this area of, quote, social determinants of health. Just quick show of hands, by the way. How many people in this room are somewhere in the healthcare profession? You know, doctors, nurses, work in a hospital, work in a system connected to hospitals or healthcare? A few, but not many. Okay. Most of you presumably are otherwise, how many in the human services field, providing direct services, one form or another? Good. And others who are working in the policy space? Terrific. So I think that covers, I'm sure I missed a few, but I think it covers a few. Well, I'm a pediatrician, actually, even though I'm working in this human services space. And I want to just talk a little about this field of social determinants. Most people, when they think of healthcare, they think about the medicines they get. They think maybe about Joe Biden's cancer moonshot and all the great new technology that's out there. But that wasn't how medicine always was. If you look back to the 19th century, one of the most famous physician scientists was a German physician called Rudolf Virchow. And in med school, we learn about how he discovered various bacteria and all that. But he has a great quote. He says, "Medicine is social science, and politics is nothing but medicine on a grand scale." Abraham Jacobi is considered the founder of pediatrics in the United States. Somebody, you know, I'm a pediatrician. We all know about Jacobi's textbook. Most people don't know that he was actually jailed when he was in Germany for being a close friend of Marx and standing up for the revolution. And when he moved to the United States and worked here, in addition to his work in pediatrics and his work actually in child welfare, where he was kicked off the board of an orphanage because he protested the conditions in which children were held, he also founded the Communist Party in the United States, again back in the 19th century. Very consciously, medicine in the early 20th century put all that social stuff underground. It said, we're all about science. We're all about what happens in the laboratory. We have to get rid of all that social policy stuff. As I'm sure Michael Curry will talk to us, medicine sort of found itself recognizing some of these social issues back in the 1960s as we founded the Community Health Center movement. Jack Geiger, whom you might hear more about, when he founded the health center in Mound Bayou, Mississippi, is famous for writing prescriptions for food, because that's what helps keep people healthy. And he was also famous for trying to include a tractor in the budget of his community health center, because again, that's what the people in his community needed in order to produce the food in order to be healthy. But that too was pressured to go underground, and we'll hear more about how the health centers got pressured. Many of you heard from Raj Chetty yesterday. He spoke passionately and wonderfully about all the great work he's done about economic mobility. He published a critically important paper just prior to the pandemic that got a lot of attention in medical circles that again woke people up, because it said that the poorest Americans live 14 years on average less, fewer lives, than the most wealthy Americans. Unequivocal data looking at people depending on their income in their 40s, what it does for their lifespan over the course of their lives. Now then the pandemic hit, and these topics became front page news. We saw who was dying first in the pandemic. Clearly it was those who were poor, those who were living in crowded conditions, people of color, particularly black people. We saw that in New York, both in terms of the rate of getting COVID and the hospitals and healthcare systems to which they went and received care that obviously was not good enough. And even today, so just today as I was thinking about this, I was looking through my healthcare notes and I saw a couple other things. One, I learned that maternal mortality, that is death of women during or shortly after childbirth, we already knew that the US has the highest rate of maternal mortality among all developed nations. We already knew that maternal mortality rates are multiple times higher for black women than they are for white women. But what we learned today, or what I saw today, was first of all that those disparities went higher during the pandemic, in part because of COVID, in part because who got COVID. And also I learned today that in fact homicide is the highest cause of maternal mortality in the United States. Homicide, that is getting killed during pregnancy and during the short period after childbirth, is the most likely contributor to death as a result for pregnant women in the US. So you can be providing the best medicine to everybody in the world, in the country, and you would not be addressing these conditions and not be improving the health and the well-being of our country. So that's just the background that we want to give as we talk about the social determinants. So now I'm going to hand the podium over to Michael Curry, and let me give Michael a brief introduction. Those of us in Massachusetts know him, but those from elsewhere might not. He's the CEO of the Massachusetts League of Community Health Centers. That represents 52 community health centers serving over 1 million patients with over 314 practice sites across our state, also known as a Commonwealth. He was also the Deputy CEO and General Counsel for the Mass League, and then before that he was, should have been on silent, my apologies. He was the Senior Policy Advisor for Corporate Affairs at Blue Cross Blue Shield of Massachusetts. He worked for Governor Deval Patrick and former Mayor and current Labor Secretary Marty Walsh. He is also, importantly, the past president of the Boston branch of the NAACP from 2011 and 2016, and has over 20 years of service to the NAACP. I could go on and on about his ongoing work, which is tremendous, but I think rather than hear me talk about all his wonderful accolades and accomplishment, I want you to hear from him directly. Michael?
Thank you, and thank you for that introduction. I know there's only a limited amount of time, and I want to get to the panel discussion. So I'm going to try to move quickly through some slides and then really sit down and engage in what I hope to be a dialogue, and I hope that we get a chance to hear from you as well. I will tell you the way I came into this work. I'm a born and bred civil rights guy, was a person who grew up in Roxbury here in Boston. Those of us from Roxbury, we always cheer when we hear Roxbury come on. And my mother was one of those mothers, if you've ever read Isabel Wilkerson's book, Warmth of Other Suns, one of those black mothers and fathers who moved from the Jim Crow South, the 6 million or so who left the South and moved north for jobs. My mother was one of those folks in the 50s and 60s, particularly. Moved from Alabama to Boston. We were latchkey kids. We were raised in the projects, came home, really took care of ourselves. And my mother had what too many black women across this country, particularly in Boston, relegated to domestic work. So she took care of white families and hotel work for most of my life. In fact, she still does that to this day. So I grew up in a neighborhood where when I walked out my front door, I lived with black and Latina folks who lived shorter lives, who were all poor. Most of us were on welfare. I lived in communities where there was high rates of violence and crime, and before we had this empathy for substance use disorder, folks treated the people who were crack addicts at that time as if they were an embarrassment, a scourge, and there was a treatment of people who were dealing with substance use disorder at that time. I lived in neighborhoods we didn't feel like we were at home. We went downtown. We were followed around department stores. We were treated a different way. We went to restaurants and to avail ourselves of the services of the city then and arguably even to this day. That was my experience. And I realized something as a child was when I left Boston to go visit family in Montgomery or Birmingham, or when I went to college in Minneapolis, St. Paul, or when I'd visit folks in Chicago on the South Side, and when I'd visit folks in Atlanta and Georgia, in D.C., as a young person, they were living the exact same way. They were dealing with the exact same circumstances. They went home to their families, and their families, their aunties and their uncles and them were dying of cancer, almost every form of cancer, diabetes, lupus, heart disease at a high rate. They didn't live to 75. They didn't make it to that age that you get a vaccine and you're the first in line to get a vaccine. They died at 40, 50, 60. So as was said, we tend to have these epiphanies in society. George Floyd dies, and all of a sudden we realize racism's real. When those who were in the trenches and actually reading and analyzing data and paying attention know that there was always a reason for these inequities because they were paying attention. We also should have known prior to COVID that disease is real and it disparately impacts some more than others. Ayanna Pressley, a good friend of Mayor Janey and I, Congresswoman Pressley, she always says those closest to the pain should be closest to the power. I talk about being closest to the disease because, as we were talking about earlier, the poor people are closest to the disease. They can't remote in, they can't virtual into work. They got to show up because they're the store clerk, the first responder, they work at the hospital. Quite frankly, they live in congested households. Because of environmental circumstances, they're closest to disease. They have 2+ comorbidities. Some of you in the room go home to families with those diseases right now, and none of it was ever normal. Shouldn't have been normal. None of it was ever acceptable. So when you talk this conversation today about social determinants of health, one, I love Disrupting Policy Conference, just the title I love, because every room I go into, I say, we need to now embrace the word disruption. Nothing really changes ever in this world without disruption. And we tend to make it a negative word when in fact it's a powerfully positive word. How do we disrupt things that we've been weathered to in a way that dramatically change situations and circumstances, and I would argue mortality and morbidity in this country? So let me jump in with some quick slides, and then I want to start us off here. So one is giving you a context for one of the things I was asked to talk about, the birth of community health centers, as was teed up. So I want to get you thinking about the 1960s. I'm a civil rights person. I do a training across the country called Quantum Leap, after the TV show actually, which just started back, where I actually ask people to jump through time from 1619 and the arrival of the slaves to today, and I make the dots, connect the dots between economic inequities and housing inequities and health disparities. I'll introduce you in that presentation to J. Marion Sims, who was the father of gynecology in the 19th century. And how did he become so famous? He experimented on black women. When it was inappropriate to experiment on women generally at that time, he had a sample of black women that were slaves, Annika, Lucy, and Betsy. I always say their names. Annika, Lucy, and Betsy. He experimented on them without anesthesia, when there was at some point anesthesia in that period of time, because, of course, as we know then and now, black people don't experience pain the same way, because our lives didn't matter then, arguably now. So you could experiment on. So then decades later, when Tuskegee syphilis experiment, and we were the syphilis-soaked race, that should not surprise you either, because the science said we were the syphilis-soaked race. I'm not talking about quack doctors, right? I'm talking about it was the established science, or at least a scientific argument, that black people carried syphilis. It didn't matter about the environments they lived in, right? So I want you to think about why we won't take vaccines sometimes, and why we don't trust systems, why we won't go to the hospital, why we don't get contact traced, because there's a context for it. So 1960s, poverty rate in the United States was 19%, high. When we think about the poverty rate now, I think 10.4 in Massachusetts, 11.6, I think, in the country. Populations were disproportionately affected by poverty were black Americans, Asian, Native Americans, individuals and families living in urban and rural communities. Between 1964 and 1965, President Johnson laid out his blueprint for the Great Society, a set of domestic programs focused on eliminating racial justice and poverty and reducing crime and improving the environment. I know some of you took history classes and was bored as hell when you sat in them classes, because I was. But I would argue if people presented history to you in a way that you could have connected to, that was real, that spoke to your lived experience, that spoke to what you saw and when you walked out of your door, you would think of history so much differently. So the cornerstone of the Great Society was the War on Poverty initiative, which ultimately produced many social empowerment programs that still exist today, including community health centers. So 1960s, Martin Luther King, and people have seen those images. If you do not, I'm gonna ask people, because I give out homework when I speak somewhere. So, and I know you may come, I didn't come here to get homework, I'm giving you homework. I need you to, if you got a pen or a computer, write this down. It's a 22-minute video. No one should walk out of here and not do this homework, for your own sake. It's a video called Out in the Rural. 22-minute video, you can YouTube it, look it up on YouTube, Out in the Rural. It's a 20-minute video that speaks to what he just talked about, Jack Geiger, why this movement started. So I'm just gonna give you a USA Today version, but you have to watch this video because now you'll think about the communities that we talk about, that we represent in a different way than you did before you watched this video. 1960s, you saw Birmingham or Birmingham. In 1960s, you saw the Freedom Rides and those buses going south to challenge segregation. And John Lewis, the young John Lewis, getting beat in the head in the Edmund Pettus Bridge in Selma. President Johnson's Great Society, historic passage of Medicare and Medicaid. Now, I tell people all the time, people think about civil rights history. I say 1964 Voting Rights Act, 1965, no, I'm sorry, Civil Rights Act, 1965 Voting Rights Act. You've never heard, probably never heard, people tell you that Medicare and Medicaid were civil rights bills. They were civil rights bills because many of the hospitals in this country were segregated in this country, and it was Medicare and Medicaid that forced them to integrate. That was part of the strategy. So we think about the 1960s, all this dramatic disruption to how we think about healthcare and community and what we call social determinants of health. We necessarily hadn't popularized that term at that point. In that process was the creation of the Office of Economic Opportunity, the lack of primary care physicians practicing in urban and rural settings across the country was the context for that time period. And then I want to give you this direct history about the work that I do now. 1965, the nation's first community health centers were launched as a small demonstration program as part of President Johnson's Office of Economic Opportunity, roots in both the civil rights movement and the war on poverty. I wouldn't do this work if it wasn't tied to my personal mission, which is to do something about racism. I wouldn't be in this job. The reason I can do this job of representing community health centers in Massachusetts and advocating from across the country is because the architects of this movement were in Selma. They were at the Medical Committee for Civil Rights. They founded the Medical Committee for Civil Rights. They knew Dr. King. They helped John Lewis come to Massachusetts to get care when he was beaten in Selma. So earliest health centers had their mission no less than using the health center system to change the health and lives of their communities and residents. Community health centers were created out of the American Civil Rights Movement, as I said, in the 1960s, and civil rights workers launched the vision of centers, of the centers and first centers themselves. Thus, community health centers and civil rights are connected through a common history. So some names just to know and be familiar with, because there are a lot of unsung heroes, and unless you go to medical school, you may not know these names, but they're equally as important, I would argue, to John Lewis and Dr. King. And if Dr. King and John Lewis was here, they would talk about Jack Geiger. They would tell you about how important he was, because as we were integrating schools and desegregating lunch counters, the caboose of that movement was healthcare. When in fact, it was probably the most important because people were living in conditions that made them live shorter lives and live sicker lives. So Dr. H. Jack Geiger and Count Gibson were Tufts University Medical School, Dr. Hatch, professor of preventive medicine at Tufts University, and Dr. L.C. Dorsey, Dr. Andrew James, and a favorite of mine, Dr. Robert Smith, who practices still to this day, and he's like 90-something in Mississippi. He was the movement that led to black physicians organizing to be disruptive about racism in this country and healthcare. So the first two health centers were in two places. First health center was in Columbia Point. I grew up in Lenox Street Housing Project. You could take a quick ride, Lenox Street Housing Project. You could take a quick ride, and in 5 minutes, you can be in Columbia Point, which is in Dorchester. My sisters grew up in Columbia Point. They got their care as children at Columbia Point Health Center. Jack Geiger when he was there to launch the health center among Senator Kennedy and others. But I want to give you this quote as we try to move quickly to conversation. Jack Geiger wrote in 1969, very important. Right now, we health professionals are standing in the middle of an endlessly revolving door, doing some good on a short-term basis. But we cannot go on providing health services without regard to the system in which the roots of poverty, sickness, and many other social ills are embedded. We have to be willing to identify the real problems and confront them. We have to create new social institutions appropriate to the problem. And finally, we need a sense of passionate commitment to bring about the changes that are so urgently needed. Now, people know this quote. You probably see it everywhere. There's some history behind it that most people don't know. So, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. As you see on the slide there, this quote comes from the Medical Committee for Civil Rights, a group of healthcare activists whose work in the late 1960s and early 1970s drew attention to inequities in healthcare in the United States. The committee was part of a larger civil rights movement in the United States. Now, what's interesting, without going too deep into this, is that actually that's not what Dr. King said. The actual quote is different than this, but I'll point out one difference. He said, of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. So I want you to think about the distinction between inhumane and inhuman. And the fact that in this country we've gotten used to people living in poor conditions and dying early and being mistreated in systems, it got normalized. So Massachusetts, I get to represent 52 organizations across Massachusetts, 52 nonprofits, serving 1 million patients out of 300 plus practice sites. If you've seen one health center. You walk into one, it may treat a Cape Verdean and Haitian population, Brockton. You may go west to western part of the state, Caring Health Center, and it's a South American and a Russian population. You can go across this state and you'll see a demographic difference, and we speak their language. Oftentimes the person greeting you at the front door speaks your language, comes from your culture, may even live next door to you. And in many cases, not enough cases, but in many cases, the person providing care for you may have your culture and share your background. Not enough, because the pipeline is a whole nother issue. So broad range of primary and preventive care, pioneers in the integration of behavioral health and dental care, treating the whole person, the whole body. Eliminating health disparities is a role that we've had since Jack Geiger and others launched this movement in the 1960s, and challenging what it means to deliver effective health care. Ethnicity, 33% of our patients identify as Hispanic and Latinx. 69% of our Massachusetts Health Center patients identify as racial or ethnic minorities, which is why when they prioritize vaccines and testing, they channel that money at health centers here and across the country. Because they knew if you wanted to do something about equitable distribution of testing, contact tracing, and vaccines and therapeutics, you had to go through health centers here and across the country. And 39.1% of patients are best served in a language other than English. 86.8% of health center patients are low income. 68.8% are publicly insured or uninsured. In fact, for those who are not from Massachusetts, we have the lowest uninsured rate in the country. But here's the surprise. We still have uninsured people in Massachusetts. The majority of those uninsured people, some of whom are undocumented, still get their care at a community health center here in Massachusetts. We're economic engines. For those of us like Kim and I who come out of Roxbury, you know the importance of having institutions that employ large numbers of people, that have a budget that then creates these secondary businesses, the mom and pop shops and the cleaners across the street, and other businesses that thrive because you're bringing business to the community. We're economic engines throughout the Commonwealth. And then I just want to move on. So really quickly, I need us to not be weathered to numbers. As we sit here right now, over 620 million cases of COVID-19 worldwide and 6.5 million deaths. I need you to not get weathered to that, because I think we are. The CNN doesn't even keep it in the upper right-hand corner anymore. 6.5 million lives lost in the last 2.5 years. That's staggering. 12.7 billion vaccine doses, 97 million cases reported in the U.S., over 1 million lives. So I love a Roots video, right? And Kim knows this Roots video. I always forget the name of the video, the name of the song, but it's a video where the character's walking through a city and everybody's dead. So imagine a city like Boston where you have about 650,000, Kim, you were mayor, so I might get this number wrong. About 650,000 people in the city of Boston. Imagine everyone gone. Everyone gone. So you get the scale of how dramatic it is that we lost over 1 million lives in the U.S. since this pandemic started, more than the Spanish flu over 100 years ago. And all the equity issues we talked about, and again, the role that health centers have, contact tracing, testing, vaccinations, therapeutics. I was on the COVID-19 vaccine working group. I was on every vaccine task force known to woman and man, no exaggeration. And I didn't know how to say no because I kept saying, okay, I'll do it, yeah, I'll do it. So the governor's vaccine working group, we're on the vaccine working group. The chair, the head of the CDC, Rochelle Walensky, friend, was on that group. I didn't know her at the time. We're kind of arguing about stuff, but she was an ally on many things. We were talking about vaccines. They said, okay, who should get the vaccine first? And folks in the room said, okay, it needs to be healthcare workers, like some of you in the room. And then they said, okay, the second group needs to be 75 plus because they're in the congregate care facilities, the nursing homes, and they're more susceptible to disease. But the data said that if you're black and brown, you didn't have to be 75. In fact, many of us don't live to 75. We were dying at 40, 50, and 60. So I had to raise my hand, and it's always hard to raise your hand and make an equity argument. For anybody in the room who's ever done it, because equity costs money, equity's not convenient, equity upsets the process, and I had to raise my hand and say, wait a minute, you just showed data that said that the demographics, John Snow 101, epidemiology, the people that are dying that are black and brown and poor and immigrant are not 75. They're 40. They have comorbidities. So why are you prioritizing 75 plus only when we may need to do comorbidities and 75? We had to push and pull, there was debates, and we changed our strategy, and it wasn't perfectly what I wanted and others wanted, but it was a difference. So the second was vaccines. If it was up to some people, they would have relegated Roxbury and Southside Chicago and East St. Louis to Johnson & Johnson. Because you know black folks ain't coming back twice for a vaccine because we don't trust, right? At least that was the narrative. And we can't unbundle the packages because they're packaged so many vaccines and so many doses. We don't want to spoil any. And by the way, they have to be deep stored in deep freezers, and they're only existing in Newton Wellesley and in suburban communities. They're not in Roxbury. So we had to raise our hand in the room and say, well, that's not equity. I don't care if you have to put a deep storage freezer on Blue Hill Ave or you have to unbundle the packages and split them up between health centers. I should have access to Moderna, Pfizer, and J&J because we know there's a difference, and I don't want to wait 5 years to look back and say we did that wrong. So I'm going to end it on this, social determinants of health. Right now, everybody's saying, okay, the 80-20. This has become a real popular conversation the last year and a half, 2 years. 20% of what dictates your health status has nothing to do with the care you get. Not the doctor you see, not the health system you engage. It's all upstream. Now, I think there's something a little flawed with this chart I'm showing you, this graphic. Now, the way this breaks it out is 40% is socioeconomic factors, which again goes to social determinants of health. The 10%, which is in physical environment. The 30%, which is health behaviors, of course, whether working out, eating healthy. But I would challenge that these numbers change if you live in Flint, Michigan, right? Depending on if you live in Roxbury, maybe environmental is bigger than this, than 10%. So how we have the conversation, and whatever the numbers are, the reality is most of the work we need to do is upstream. And how do we solve for the fact that racism makes people sick? And I don't just mean trauma sick. I don't mean just mental health sick. Racism relegates you to bad neighborhoods. Racism means that you can't get that high-paying job. You can't go to college. It relegates you to poverty. It relegates you to manual jobs or essential worker jobs. And you may have been, I always tell people, Kim, I said, there's a black girl sitting in Roxbury right now on Moreland Street, right around the corner from your house, who's meant to be the person to find a cure for cancer. You'll never know her. because there's drive-by shootings in her neighborhood, because her guidance counselor or teacher doesn't believe that she's smart enough to go into that special program, or talks down to her, a self-fulfilling prophecy, or she goes home to a family where she doesn't have the social supports, or she's poor. So I want you to know how much all these environmental, social factors impact. I don't want you to do diversity for diversity's sake because it makes you feel good. I want you to realize, unless you believe in a white supremacist theory that only white men can be doctors and lawyers and C-suite and do this work, then you got to realize that talent lies in all of us. So if we realize that talent lies in all of us, why are we not investing in all of us? Why are we not being disruptive? Why are we not being disruptive about the conditions, the circumstances, the laws, the policies that relegate so many of us, particularly people who have darker skin, to conditions that they can't thrive and contribute in the way they was intended to? So social determinants of health, I won't spend time on this. You've seen it. We talk about it. Poverty, food insecurity, housing insecurity. We know what the data says. The wealth gap, achievement gap, incarceration rate. All my uncles were locked up. I spent most of my childhood visiting Concord, Walpole Prison, going through those big doors, the police officer with the gun pointed at you, and I'm 7 years old visiting uncles for nonviolent drug offenses. Poverty rates. I want to give you this weathering. So weathering, I need to leave you with this, and then we'll jump into this discussion. If I could tell anything to anybody, anywhere, this is the thing that I always remember, because it brought context to my life. I was in a training a few years ago, and the researchers came in. They said, we want to introduce you to the weathering effect. They said, we want to give you an example of asthma, Michael. We asked black parents to rate their kids' asthma from 1 to 10, and black parents, like my mother, I had asthma, my sister had asthma. I'm out of breath right now. My mother had asthma, my sister had asthma. We spent a lot of time dealing with that condition. The doctor said those black parents rated the kids' asthma in 3, 4s, and 5s. And then the doctors evaluated those same kids on that scale, and they were 8, 9s, and 10s, and they said, Michael, that's the weathering effect. You can get so weathered to being sick that it becomes normal to take the Alupent and the Flovent 3, 4 times a day, to be bent over because you can't breathe, to skip the gym and not go to work, and to sit in the emergency room like we did at Boston City Hospital once a month or once a quarter. None of it was ever normal. The diabetes rates in your neighborhoods and your communities has never been normal. It was never acceptable. It was always preventable. The cancer rates, we just celebrated that the breast cancer rates are down, the mortality rate from breast cancer. Hey, let's celebrate, except for black women. So can we celebrate? Are we weathered to the fact that if you're a black woman in this country, you're likely to have your best childbearing years may be your teenage years, which is where the weathering concept came from. The woman who popularized the term talked about in her research, the best childbearing years for a black woman was teenage years. For a white woman, it was much older. Is that because black women are just naturally prone to have, difficult pregnancies? Of course not. Rebecca Lee Crumpler, one of my favorite black women of all time, favorite people of all time. She was the first African-American female physician in the 1860s, right at the end of slavery and into Reconstruction. She worked during Reconstruction. I say one of the baddest sisters I've ever heard about. She said they seem to forget there's a cause for every ailment, and it may be in their power to remove it. So I want you to remember that. They seem to forget there's a cause for every ailment, and it may be in their power to remove it. That's what this conversation about social determinants of health is about. So when you think about how many more times we're likely to have a cancer rate or a diabetes diagnosis or live in poverty or be homeless or be shot in a community violence or be shot by a police officer, 2, 3 times more and more. Like all of that you should not be weathered to that data. Do not sit in this room and say, oh, well, it is what it is. Because that's a child. That's a family that you're serving. And in order to change it, you got to be uncomfortable with it. You got to be disruptive about it. You got to be impatient with our lack of movement to change conditions and circumstances. And you got to dismantle racism. Because it's embedded and woven into this country as much as anything else. It is how we think about things, consciously or not. So I'll end it on social determinants of health of saying we have a lot of work to do. And I hope this conversation, this conference becomes a catalyst for change and disruption across the country. Thank you.
Wow. So let me introduce our other panel member, Gabe McGauhey. I hope I pronounced it reasonably
You did, but
correct.
next time I go first.
We do have some boundary crossing folks here. I mean, you've got a pediatrician working in human services, you got an NAACP lawyer leading community health centers, and now we have somebody who is working at a Children's Hospital of Wisconsin, I believe, right? Mm-hmm. Who in fact is leading their community services programs, and especially their child welfare activities. So he hopes to push the child welfare and other public systems to a more holistic approach to working with children to improve both their immediate health, which we've talked about, and their long-term well-being. He was the director of the Children's Child Welfare Program, oversaw its implementation. He's been working for more than 16 years in the field of social work and group homes. He's got a background in quality improvement, also near and dear to my heart. And Gabe, why don't you tell us, maybe start off by talking a little bit about your work at Children's of Wisconsin, why a hospital is operating a child welfare agency, how that fits, and what you're trying to do with that.
Good questions. So thanks for having me. I appreciate, Michael, your presentation. I thought it was great. When you think about social determinants of health and why a children's hospital might be involved in child welfare, I think taking a step back, when that slide that talked about the social determinants of health, and like the 20% is high quality health care, and I've heard it's even less than that sometimes. Yeah. Which is to say, all of you are actually in the healthcare business. So if you're working around housing, if you're working around economic support, if you're working around jobs and employment, you are in the healthcare space. If you're working around housing, you are in the child abuse prevention space. So what I like about the social determinants of health, it challenges us to how do we come together and start to see the holistic picture? And how do we start to see these issues as our shared issues and break away from these silos that have been developed over what is really, when you look at the history, like Michael pointed out, is this historical trauma that is played out in our policies and mindsets that still exists today. The pull yourself by your bootstraps nonsense that is so prevalent and such a barrier to a lot of our families getting access to the supports that they need. So when you think about why should a children's hospital or any health system be involved in child welfare, you think about child welfare when they talked about the social safety nets yesterday. Child welfare is really the backstop. That's the end of, that's where when the systems have completely failed these families, that's where they go. That's where they end up. And most of the time, 70% of the time, it's for reasons of neglect. So when we talk about child welfare, I think people think about horrible abuse and everything like that, and that happens, that still exists, but it's only 30% of the reason kids are separated by the government into foster care, separated by their families. The government takes kids away from their families, and we have to do that very thoughtfully. And if you think about it, 3 out of every 10, 37%, I think Marla mentioned this in her presentation earlier, 37% of all children in the US will be subject to a CPS investigation before their 18th birthday. 53% of black kids will be subject to a CPS investigation by their 18th birthday. And 1 in 10 kids will be, have confirmed substantiated maltreatment or confirmed abuse before their 18th birthday. And we also know that when you look at adverse childhood experience scores or anything like that, the systems are not protecting everybody. It's failing. So the question is, then what? How do we kind of reimagine? We can't accept that the current state, and you get a lot of resistance to change, anything, but the current state isn't any good for anybody. If you look at child welfare and, kids who are sexually abused don't get taken care of correctly. Physical abuse is one thing, but most kids come in for reasons of neglect. And I think one of the challenges are the mindsets and how we look at it. And I think Children's Hospital being involved with child welfare, we came in at a unique time in the early aughts when privatization was happening. But the reason why we should care about healthcare is twofold. One, child welfare is a social justice issue. And two, these kids are the kids you will see and all the negative outcomes you want to list. More likely being incarcerated, worse health outcomes. When they are in care, we discover how many health outcomes that they haven't been treated, that have not been treated. So I think children's hospitals can play a unique role in addressing the needs of these children and addressing the well-beings. And besides doing a child welfare program, we also have family preservation programs, mental health programs, employment opportunity programs, including one of my colleagues here. And so when we start thinking about it and looking at health more holistically, I think we start realizing that the social, the community partners, the people doing services in the community are essential to actually improving the health and well-being of kids and families in our communities.
Gabe, maybe if I could follow up on some of your points. I mean, again, the overwhelming majority of cases in the child welfare system are neglect. There are huge racial disparities in who gets reported into child welfare systems. And, poverty and racism really are the underlying drivers. And our society, it wasn't really that long ago. I mean, it was really, again, in the 60s and 70s, chose to sort of focus on the abuse and neglect and treatment rather than perhaps a more substantial investment to address the underlying root causes. So what's the responsibility of current child welfare entities to, again, move upstream and sort of shift from this treatment approach to a true prevention approach?
I think when we start talking about that shift, and there's been a shift in the field towards prevention, it's more early intervention than prevention right now. So the Family Preservation Act that was passed at the federal level offers up more flexibility in funding, but doesn't give you more funding, right? So you can get creative with your states, can get creative with their funding and make some shifts towards, but still families who already have contact with child welfare. So I think when we start thinking about what's the role of child welfare, you get into a really interesting conversation. Is it child protection? Are you intervening at the point of maltreatment or, making sure kids get back faster? Our history in our field is one that really focused on, staying away from these issues that feel like are drivers outside of our field, outside of our control. But we need to start talking more about poverty. Not because poor kids are being maltreated, but they're more likely to be policed by the child welfare system. If you look at, the child welfare system is really crafted by the Adoption Safe Families Act, really set our current system up in 1999. It's passed by the same Congress that passed the crime bill and passed TANF. And we can understand that those were hugely devastating to communities of color and really rooted in that historical trauma and that mindset that really continues to persist and present barriers to lasting change.
And Michael, maybe a similar-ish question to you. I mean, it's great that the healthcare system has kind of woken up to social determinants. But I would say even the most progressive health systems, or at least what I see as the more progressive health systems now, are screening for what some of us call health-related social needs, whether people are hungry, whether they're housing instability, and maybe referring them to services for that, but stops there. I mean, you pointed out the critical role of racism. The World Health Organization, when it talks about social determinants, says that the challenges like food insecurity and things like that are shaped by the distribution of money, power, and resources, which is, I think, a genteel way of saying what you said more forcefully. So what's the role of the healthcare system in moving upstream, to use again the language we often use in that field, to addressing these root causes rather than, or in addition to facilitating, better access to SNAP benefits or food pantries?
So great question. As I sit here and look at the screen across from me, I'm compelled to say this about social determinants of health. I always tell people, particularly because I grew up in a neighborhood with a lot of violence, I tell people, change that to social determinants of violence. So you want to talk about that kid that just did a drive-by shooting, I want you to know the conditions, the circumstances that he or she came from. We don't do that very often. We just turn on our television and say, oh yeah, there's violence in that neighborhood, those bad kids, but we don't do that. There must be a reason why a little kid at 14, 15 would pick up a gun. And we can explain that, right? So we need to determine, go upstream and figure out was the housing condition they lived in, the abuse in their home, the resources they had, the internalized racism. Because if you hate yourself, then I don't care anything about your life, right? If I hate myself, I don't care about yours. So how do we do something about that? I think to your point, we have a challenge right now in our healthcare systems. We switched to value-based care here in Massachusetts across the country, right? How do I not just do fee-for-service and sort of, as a provider, bill for something I did and then get paid for it? But how do I now get paid to treat your total health? And I would argue total health should be, though it's not really there, it's your total health is your teeth, your eyes, right? Your mental health. For any of the black people in this room, I'm gonna say this to you, and probably all of you have heard this phrase because we grew up in the houses that said this, black don't crack, right? Black don't crack, it was the resilience of our skin in the sun, it was the fact that we survived slavery and Reconstruction, Jim Crow, and racism writ large. But I always say black don't crack, but the cracking's on the inside. Go stand in Dudley Station in Roxbury, Nubian Square right now for an hour and you will see the cracking. You'll see it. Or go to Southside Chicago right now, you'll see it. So I think for us, right now in healthcare, we're trying to figure out this value-based care model. How do we now change resources, allocate resources in a way that we can get people all that they need to be healthy? And to your point, it's a challenge because it means that I need to refer you, young black man, to a training that may help you with your confidence or help you unpack your internalized racism or your trauma because you saw violence in your neighborhood, your friend was shot, or you didn't get your teeth done or your eyes done, and that's the traditional referrals we do. But some of the stuff around writing you a prescription for food, which was the model Jack Geiger brought to the health center movement, we've gotten away from that. And I will tell you nothing, and I say this when I speak to health centers across the country, and I get brought in to do these presentations. I just got back from South Carolina, and I say to people, we got to get back to our roots, because I was in South Carolina, so I didn't say roots. Get back to our roots, which means that we don't just need to refer you to the care, we need to warmly hand you off to that care. And then we need to make sure that that care is appropriate on the other side, that you have the staff, the resources, that you're going to treat them culturally competently. You'll give them the housing they need, the food they need, the counseling they need, or whatever they need. We just can no longer say, hey, good luck, and here's a number to call, because by the way, we'll see them again in a month or two or a year with the same problem, the same conditions, because they went back to the same circumstances.
So maybe following up on that, again, most of the people in this room do work in the direct services, human services field. What have you found to be the best ways to partner? What are some of the challenges actually in partnering between healthcare and human services? Because Massachusetts has been kind of pushing that, and Wisconsin's probably got a lot going on in that. And what are some of the lessons that you've learned about effective ways, both from the healthcare side and especially from the human services side, to make that an effective partnership?
When you think about the effective partnerships and what everybody you bring to the table is what will resonate with the healthcare side is understanding that your connection to having the evidence that connects your work to the healthcare outcomes. And that when I say evidence, it could be a survey you do understanding that the people you treat, X% are served by this health provider, or receiving HMO Medicaid from this provider of choice, or it could be like, hey, these are our housing issues. It could be evidence that you generate that you can then connect with, like, hey, so we run a community health plan. It's called Chorus. So hey, Chorus, I have a lot of kids here that are in foster care because their parents didn't have housing or there was unstable housing. How can we work together? Because that makes that about a benefit for them as well, but a link to their outcomes. So as a community, and what you bring, and I think that the last panel did an eloquent job of, is that community connection and authenticity and be able to reach. So one of the health outcomes, especially those who are looking at value-based health outcomes, think about HMOs as much, Medicaid HMOs as much more than, to me, than pediatric providers directly. Because the providers can only pay for what they can bill. But if you think about HMO, especially the nonprofits, when they make revenue, they can reinvest it in their programs in creative ways. So understanding that you understanding your link to the health outcomes and what evidence you can have to make that connection for them, and understanding how that aligns with their objectives. And at the same point in time, you reach the families that they can't reach, right? You have the relationships, and that's huge. And so being that bridge and being that partner in that way, I think is a great way to translate and for making a step towards improving health outcomes.
And what I would say is that there's so many lessons out of COVID-19, things that I've been in this space for a long time. And all the things that we didn't think we could do, we did during COVID-19. We didn't do telehealth here in Massachusetts, across the country. And then we had to adopt it in order to provide care. We didn't teach remotely. We didn't work remotely. And all of a sudden we realized people actually work harder at home when they got to work remotely. And quite frankly, we didn't embrace the collaborations across the systems like we learned that we could do during COVID. You had community-based organizations here in Boston, Black COVID Coalition, or Latino organizations like La Colaborativa and others, who are organizing and said, hey, you can't reach our people, but we can. You can't get them to get tested, contact, trace, but we can. We can give them information about the vaccines in ways you can't. They don't trust you, but they trust us. And we started resourcing them. Because I'm gonna tell you, I'm an NAACP dude, and if you did not know this, the NAACP across the country, we don't get paid to do that work. I was a full-time volunteer with kids in the job. And I'm sure I put in as much hours as probably everybody sitting in this room in my volunteer role as an NAACP leader. We didn't have money to do all the things we needed to do. You don't have all the resources to do all the things you need to do. So how do we resource community in a way that's respectful? One of the things that I love that's growing right now is community health workers. It is one of the dopest concepts, and it shouldn't have taken us that long to get there. People who come from communities, who speak languages and speak your culture, who can actually go into communities and convince you to check your temperature, to come in for an appointment, to go to the gym, to learn how to eat a healthy meal, to choose the better doctor, right? A community health worker that can work with you to do that, but they don't get paid squat. So if we really care about systems, how do we resource community? How do we resource? And then to that point I made around Ayanna Pressley earlier, those closest to the pain should be closest to the power. How do we change the system so that more people who actually are on the ground in service to community then have a seat at the table? One of my favorite phrases, my predecessor, and I'm sure he stole it from somebody else, but I give him credit. He says, if you're not at the table, you're on the table or you're on the menu. And this is all about who's at the table, and too many tables don't reflect the people who work with you to make sure that the policies and the practices are effective and meet the needs of people.
Well, I could keep asking questions, but I'd like to give you a chance to ask questions. So if there's any questions for the panel, we have the microphone wandering around. Please raise your hand. Are there any questions out there? Please. Is there a microphone wandering? There we go.
Thanks, and this is a question for both of you actually. So talking about child welfare and the move away from simply doing tertiary prevention, but also thinking about community outreach for healthcare, there's an implication in there about community trust. So if the community doesn't trust an institution because of the legacy of harm that it's caused over generations and centuries, what is it that we can do to repair some of that trust in order to have the door that we're opening invite people to walk through?
I'll start off with, I'm going to use an example of a partner that we work with, Boston Medical Center here in Boston, which is a health safety net hospital. They serve a high population of Medicaid, Medicare. Many of our victims of violence get their treatment, their emergency room care at Boston Medical Center. What I love that they did something, because they're friends of mine. Dr. Thea James, the emergency room physician, Trina Martin is their head of community affairs, and they work with their CEO. They basically did something I think is the model, which is, one, tell the truth. If you want, they don't trust us because we haven't been trustworthy. Start with the truth. So if you start to say, here's where we messed up, here's our maternal health numbers, here's where we're failing, here's where we're trying to do things differently, and then hire differently. Because I guarantee you, if you hire someone like a Dr. Thea James, who the community trusts, and a Trina Martin, who the community knows, because they're in the community, then people say, okay, maybe things are changing. I'm going to go because Trina told me to come. So I still don't trust you, system, but I trust her. And if she tells me things are different and you've given me historical context, you've been honest enough, then I'm going to give it a try. And I think we don't do that in this country. And in fact, this whole critical race theory thing, we like to ignore the past and start over. When in fact, that pays no respect to those of us who've experienced it, lived it, and then it tells us we're crazy, right? It gaslights us. So then you don't gain our trust.
The only thing I would add is to think about, like, it's actually more, it takes more time to engage the community, right? And what we were trying to do in some of our work is, like, how do you build a shared understanding and reach out to the not usual suspects? Because I have the people with lived experience who are the usual suspects, who are on every lived experience panel, and they're wonderful and they're great. But how do I, like, for me, one of the challenges in our work is, like, how do we reach the tribes? Because tribal distrust of child welfare is righteous and rooted in a really recent history, right? So how do we start reaching out to the non-usual suspects? And how do we start to find alignment? Not necessarily consensus, but alignment. And all of this takes more time, but it's actually more efficient in the long run, right? So as much as it feels like bringing people in, and, have everybody at the table, like Michael was talking about, feels like, God, it's taken us so long to get anywhere, to find, you're right, it's going to take you longer, but you will find a more efficient, because otherwise you're going to do the same thing we've always done, which is jump to a solution that imposes on the community. It doesn't work.
Yep.
Well, we have one more question. Good, we'll squeeze in time for one
Hi,
more.
Dave Lash, consultant. Working in communities, doing collective impact initiatives in many cities, loosely associated with social determinants of health. One of the execution challenges is the shared data system.
Yes.
The silos between organizations are so structurally rigid around the data systems, and I'm just curious, both in terms of a startup kind of breakthrough idea that you might have, or longer range, what do we do about that?
And maybe a quick one for me is that this is about movements, right? And the question is always whether this is a moment or a movement. And to me, this is becoming a movement in Massachusetts. A group of us got together after maybe a year into COVID, and we had been all these task forces. And we said, we're Black and Latinx leaders running health systems. So the head of Children's Hospital here is an African-American man. The head of Point 32, a health plan, is an African-American man. And a high-ranking Latina sister at Tufts Medical, and 60 of us now, who quite frankly, our systems don't always want to do the right things, right? But we decided that we're going to come together and force the things like data. We have to collect data better. So we're actually, you didn't hear about this yet, and if you repeat it, I'm going to say I didn't tell you this, right? Out of Massachusetts, we were the start of health reform. We passed Chapter 58, 224, 305. ACA was modeled in large part after the work here in Massachusetts. The next train leaving the station in health reform in Massachusetts is a health equity reform bill that this group of 60 are crafting right now and going to propose to the legislature for the next session to say we want everything in this bill to be about health equity. Data is a critical part of that. How do we make sure we gather data and we could communicate like we did during COVID, because we found a way during COVID. You got a vaccine, you're a patient at his hospital, but you got a vaccine over here, and for some reason we knew both places were communicating with the data in some places, and we knew you got your shots. We shouldn't have to wait to a pandemic to figure that kind of stuff out. So that's part of the model.
So I have a very rich history with data, so I understand like the pain and trying to like make everything go together. And I think one of the best suggestion I have is like setting as simplistic North Stars as you can. And I'm more used to like, one of our initiatives is focused on reducing the number of family separations for reasons of neglect, which is very specific. It's very long term, but it's actually measurable and it's a reduction. And I think when we think about collective impact or systems change, thinking about it in terms of contribution rather than attribution, right? So in schools, we're often taught, like in grad school, social work, I'll speak for social work, pre-test, post-test, 1 + 1 = 2. But in systems change, it's like 1 + 1 = 4. It doesn't always, and because somebody wrote a book, like all of a sudden eviction was a big deal, back especially in Milwaukee. The book was great. And it was like, okay, all of a sudden eviction's there. You never know as you're kind of grinding on this and putting into this one, something's going to push your headwind forward. I'm not saying I'm answering your question around the data, but I respect that struggle, and I figuring out like what you can do, doing something, don't let perfect be the enemy of the good, right? And see what you can do and include as many voices and be as transparent as you can and say, hey, this is what we can do. This is what our collective, what we can get at. We want more. And as you kind of engage the community, how can you put pressure on those other stakeholders or other people to like kind of pony up with the data, especially states that may not be on board right away.
And just to build on that, and then we'll close up. So, I mean, as Michael said, when there are crises, they can solve this. So Massachusetts, like many places, has a severe problem with opiates, opioid use disorder. And again, all of our data systems are fragmented, but the governor said, time to work on this, the legislature did, and they were able to suddenly magically come up with ways of linking data, and we learned that, in fact, individuals, as they leave incarceration, are 15 times as likely to die within 2 weeks following release from incarceration from opioid use disorder, because they were able to link public health data and Department of Corrections data, which they had never been able to do before. So we just need to create the compelling case and build the political will, because the capacity is definitely there. And there are several national movements going on and organizations really working on this linking of human services and health data. And if you're not connected to them, I'll be happy to talk to you again. I want to ask you to just give an applause for our wonderful panel, and then give you an opportunity. And I believe schedule-wise, we have a break now, and then the movie is going to be back here. Is that correct?
Yes, that's right.
Yeah,
you said it right. Can you say it again? 15 minutes?
So we have a 15-minute break, and then back here we have the movie, which will 10 minutes. Back in this room, which will give the movie is about Chelsea, right? And
That's right. Yeah, the guarantee. Here he's coming. Yeah, let's jump up for a second. Oh, thank you. Thank you. Yeah, back here at 3:45, there will be the screening of Raising the Floor, which is a 30-minute documentary about the Chelsea Eats program, which you heard a speaker speak about earlier. And the filmmakers will be here. There'll be a Q&A, so please stick around.
We gotta stay